So, as promised, I am going to record a few of these lectures that are easier to understand than things that we're going to go over on Monday. And it will also allow us to have some time on Monday to do a real patient interaction. So we're going to start with dementia and memory loss. But before we can really discuss dementia, we need to be able to differentiate between dementia and delirium. So first we'll talk about delirium. Delirium is going to be a very sudden, severe confusion. It's a much more acute onset than dementia. So the patient will be normal one day and then not normal the next day or within days or weeks. Delirium also tends to have a fluctuating course, and these patients will be delirious and then also have some lucid intervals. Delirium tends to be worse at night. There's also a shorter time course overall with delirium. So these patients will have symptoms that last hours to weeks rather than months or years. Their thought processes also tend to be very disorganized. So patients may be incoherent on initial presentation. Disorientation is very common. Disorientation to time is particularly affected. And the patients will have fluctuating attention, so they will be easily distracted, not able to concentrate on selected tasks. Examples here would be alcohol withdrawal and acute hepatic failure. Dementia, on the other hand, is an acquired cognitive and behavioral impairment that interferes with social and occupational functioning. So when you think dementia, you want to think generalized, sustained, progressive. So these disease processes will be insidious or have a slow onset. Usually it is a slow, steady, and progressive decline. It lasts longer than delirium, so we're talking months to years, and thought processes tend to be impoverished rather than disorganized. So patients will not have as much input to questions. They really won't be able to come up with much information on their own, in contrast to the delirium patient who really is who has a lot of content, but it's very disorganized. Orientation is fairly well maintained until later stages of illness, and attention tends to be unaffected until late in the illness. So some of these clinical characteristics can help you distinguish between dementia and delirium. And a couple examples of dementia are going to be B12 deficiency and Alzheimer's dementia. So when we evaluate dementia, there are lots of important questions that we need to ask the patient. So for history, we need to question the patient and family about cognitive, memory, and behavioral problems. Very important that we talk to family in this case, because very often the patient will not have enough insight into his or her own deficits to be able to give us an appropriate history. So we'll ask for specific examples of whether the deficits have affected the patient's daily life. So has memory or concentration led to problems at work, or have personality or behavior changes strained family relationships, these type of things. It's also very important to get a really good sense of the temporal course of the illness. So did the changes start days or weeks ago, or has it been going on for months or years? Have the deficits gotten worse or stayed the same? And this will help you to differentiate also between delirium and dementia. We also want to evaluate patients for neurovascular risk factors, so hypertension, diabetes, history of coronary artery disease. All of these things may indicate a dementia that's of neurovascular origin. Specific components of the physical exam that are important to include are going to be the Mini-Mental Status or the Mini-Mental State exam. It's likely the most important part of your objective assessment. We also want to look at specific neurologic abnormalities. So one thing that we will look at specifically is the frontal lobe release signs. There is a link here to a YouTube video that you can take a look at. What these are primitive reflexes that appear when there's damage to the frontal lobe. So in a normal patient, the frontal lobe will inhibit these reflexes. Once the frontal lobe is affected, though, the patient loses its ability, or the brain loses its ability to inhibit the reflex. So two examples are going to be the snout and grasp reflex. As you look at the YouTube video, the the examiner actually presses his thumb against the patient's lips, and her lips purse or make a kissing motion. Another way to elicit this reflex without touching the patient's mouth is to place a tongue depressor on the patient's lips and then just lightly tap with a reflex hammer, and you'll see that pursing motion of the lips. The grasp reflex is basically when you run your fingers along the palms, along the underside of the hand, and these patients will actually curl their fingers in a motion to sort of grab onto the examiner's hands. We also want to look at abnormal eye movements such as nystagmus, which may indicate a toxic ingestion. We want to look at motory exams for signs of extrapyramidal features, things like cogwheeling rigidity, which we talked about in class, and any involuntary movements. Sensory exam needs to focus on signs of peripheral neuropathy, things that might indicate a B12 deficiency. So according to the American Academy of Neurology, the guidelines for appropriate lab studies are outlined here. The things that we're looking for are all things that can cause different types of dementia. We see dementia in hypothyroid patients, certainly with B12 deficiency, patients who have syphilis. All of these things can lead to dementia, so we're going to look at all these things. Imaging studies are considered appropriate for an initial evaluation. MRI is going to be preferable when financially reasonable because it's more sensitive in evaluating the smaller structures like the hippocampus, which are very often involved in dementia patients. When imaging becomes imperative, there are times when imaging becomes imperative. So if the patient presents very young, under the age of 50, if the onset of symptoms is abrupt rather than insidious, if the patient has focal exam findings, so things like pronator drift, or a constant progressive unilateral headache, or any other history that suggests a mass lesion, then we'd want to do an imaging study, or if the patient has a history of stroke. We also want to think about doing an LP if there's a history that suggests an infectious process, a normal pressure hydrocephalus, or Creutzfeldt-Jakob disease, and we're going to talk about each of these in turn. Lots of tools to evaluate a patient's mental state. These tools vary greatly in their level of sophistication. Mental status is evaluated, albeit crudely, during every patient encounter in the form of simple observation, history taking, listening to the patient's thought process and listening to them talk back. How do they cooperate during the physical exam? All of these things are part of the patient's mental status. So even during a brief interview, you can comment on whether the patient's stressed appropriately, whether he's responding appropriately, and whether he's able to attend to your questions and attend to the physical exam. On the other end of the spectrum is going to be neurological or neuropsychological testing, so neuropsych testing, which is very sophisticated testing. It measures memory, concentration, visual spatial skills, problem solving, counting, language skills. Very, very in-depth. Takes anywhere from 3 to 12 hours to complete and is extremely expensive. So we won't often use this for patients who have, your run-of-the-mill dementias. One instance in which we do use neuropsychological testing is if we are evaluating a patient for seizure surgery. The neuropsych testing is just one piece of the puzzle that helps us to determine where the seizures are coming from. So the focus of the seizures or the seizure location. We also have a rapid screening tool called the Mini-Cog, and we'll talk about that next. So the Mini-Cog is a really good screening tool if the cognitive impairment is suspected or if a patient comes in with complaints of memory loss. It's really easy, quick to administer, but it may not be useful in patients who have visual impairment or difficulty holding a writing instrument, a pen or a pencil, because half of the test consists of a clock drawing test. So finally, it's important to understand the only things that this tool formally evaluates is executive functioning, visuospatial skills, and immediate recall. But when you think about it, you're able to evaluate language and attention, which are the other components of the mental status exam, or the mini mental state exam, pretty effectively just by observation and interviewing and examining the patient. So this is what the Mini-Cog test looks like. It consists of a clock drawing task and recall of 3 unrelated words. So you'll use whatever words that you typically use. We need to make sure, again, that they are unrelated words. So this example here is ball, dog, and television. Classically, you hear apple, table, penny. I like to use also butterfly, tulip, honesty. The key is that they're not all 3 items of clothing, or they're not all 3 types of animals, but they need to be completely unrelated to evaluate the patient's recall. The clock drawing task is considered normal if all numbers are present, if they're all in the correct sequence, and if the hands display the correct time in a readable way. And the Mini-Cog is scored based on the following rules. Subjects recalling none of the words are automatically classified as demented. Subjects recalling all 3 words are going to be classified as non-demented. Now, if we have subjects with 1 or 2 words recall, an intermediate word recall, then we classify them based on the clock drawing test. If it's normal, then we move to non-demented. If it is abnormal, then we move to demented. So the advantages of a Mini-Cog are similar, are that it has similar specificity and sensitivity for predicting dementia status compared to the MMSE, but it takes a lot less time to administer. And also the diagnostic value is not quite as limited by the subject's education or language. It's going to be easier to communicate 3 words in a foreign language and to communicate to the patient how to draw a clock than it would be to administer the entire MMSE in a foreign language. Looking next at the etiologies of dementia, we see that Alzheimer's dementia accounts for the majority of dementia patients. So we're going to spend a particularly long time talking about that. We're also going to look at vascular dementias and several other types of dementias, but really important that you understand Alzheimer's dementia because it is by far the most prevalent cause of dementia, and you'll need to know how to manage this even in a family or internal medicine practice. So Alzheimer's dementia is the most common cause of dementia. More than 14% of individuals older than 65 years have Alzheimer's, and the prevalence increases to at least 40% in individuals over 80 years old, and the number jumps to 50% after your 90th birthday. So as you can see from these numbers, the greatest risk factor for developing Alzheimer's dementia is age. But age isn't enough. Interestingly, if you reach age 90 without developing Alzheimer's, you're not likely to develop it at all. Many studies indicate that the risk of Alzheimer's is significantly higher in women than in men, and more than 90% of cases of Alzheimer's are sporadic and occur in individuals older than 60 years. However, there is a genetic component to the disease, and without getting too heavily into the genetics, what I want you to know is that the apoprotein E, or ApoE, located on chromosome 19, is associated with the sporadic form of the disease. So as long as you kind of keep that ApoE in your head as associated to Alzheimer's, it's really all you need to know right now about the genetics of the disease. A small percentage of Alzheimer's disease patients, probably less than 5%, have a rare genetic variation, and this can be found in a small number of families worldwide. In these inherited forms of Alzheimer's, the disease tends to develop before age 65, and sometimes in individuals as young as 30. The mechanisms by which dementia leads to death are related to the complications of the dementia rather than from the pathophysiology that leads to the disease itself. So severe dementia frequently causes complications such as immobility, difficulty swallowing, malnutrition. These complications increase the risk of developing pneumonia, which has been found in several studies to be the most commonly identified cause of death among elderly patients with Alzheimer's disease and other dementias. Sorry if that was a little choppy. I had to respond to a text real quick. Next, we'll look at the pathophysiology of Alzheimer's disease. So the three hallmarks of Alzheimer's disease that you need to keep in your head are corticocerebral atrophy, neurofibrillary tangles, and amyloid plaques, specifically beta amyloid plaques. We're going to talk about each of these, and I want you to make sure that you understand the process behind each one, or the pathophysiology behind each of these different hallmarks of this disease, but don't get too caught up in that. I'm giving it to you just for clarification, but it's not necessarily something I would test you on. However, you will be tested on knowing to associate these three pathophysiologic changes with Alzheimer's disease. The first one we're going to look at is cerebrocortical atrophy. This is caused by a loss of cortical neurons. So you can see in the drawing that the left hemisphere is normal, and the hemisphere on the right, as you're looking at the drawing, the hemisphere on the right is diseased. So we have severe atrophy here. The entire Alzheimer's hemisphere is smaller. So we have generalized atrophy, and it's made apparent by the enlarged ventricles and by the widened sulci. So specifically the parts of the brain responsible for memory and language are going to be affected, and you can see those here. The second pathologic hallmark that characterizes Alzheimer's is called a neurofibrillary tangle, and it forms inside the neuron itself. So the major consistent of these neurofibrillary tangles are going to be the tau protein. In a normal healthy neuron, the connections between the neurons are made through these little tiny appendages or branches called neurites. So that's a term that refers to both axons and dendrites. The neurites contain these little microtubules that maintain the shape of the cell, and they serve to support the cell. It's sort of the life support system of the cell. They carry nutrients, they carry neurotransmitters. The walls of these microtubules are reinforced by tau proteins, but in the Alzheimer's patient, the tau proteins loosen and they congregate to form these tau proteins. And without the reinforcing effect of the tau proteins, the microtubules disintegrate, and that cuts off the life support system of the neuron, and the neuron then shrivels and dies. So what we're left with here is a destroyed neuron and this neurofibrillary tangle that is composed of all these tau proteins. The third pathologic hallmark is going to be the senile or amyloid plaque. You will hear it called both things. The major component of the amyloid plaque is going to be beta amyloid, and this is a series of diagrams sort of showing how these plaques are formed. A protein called amyloid precursor protein, APP, is produced by healthy neurons, and it can be seen up here. APP is going to be severed by two enzymes, beta and gamma secretase, and the process creates this short sticky protein called the beta amyloid protein. Instead of dissolving in the fluid that surrounds the brain and surrounds the neurons, in the Alzheimer's brain, these beta amyloid proteins fold up into these insoluble clumps, and they result in amyloid plaques on the surface of the neuron. You can see those right here. Moving on from pathophysiology to diagnosis. Diagnosis of Alzheimer's disease can be a little challenging. Classically, you may hear that definitive diagnosis requires a biopsy, but this is rarely performed. Sometimes we will confirm on autopsy that the patient did in fact have Alzheimer's disease. But researchers right now are telling us that we can diagnose Alzheimer's disease with a 90 to 95% accuracy based on careful clinical evaluation. Patients with Alzheimer's disease most commonly present with a very slowly progressive memory loss, and other spheres of cognitive impairment are added over the course of several years. So to make a diagnosis of Alzheimer's disease, what you're looking for is a progressive functional decline and dementia. So the functional decline refers to the loss of the ability to perform activities of daily living, things like feeding, dressing, toileting. The presence of dementia is established by mental status exam. It ideally should be confirmed by neuropsychological testing, but again, this doesn't happen because of the expense and extensive nature of that exam. We also want to look for levels of consciousness. So these patients must have a normal level of consciousness, and they must not have any other disease that would account for the dementia. So we have this cognitive impairment that involves a minimum of 2 of the following domains. So we have an impaired ability to acquire and remember new information, impaired reasoning and handling of complex tasks, poor judgment, impaired visuospatial skills, impaired language functioning, and changes in personality and or behavior. We do have some diagnostics that are on the horizon, biomarkers, for example. But before a biomarker can be used in medical clinics, it has to be validated, and lots of studies are needed for this to make sure that it reliably indicates the presence of disease. And the laboratory methods used to measure the biomarkers must be shown to be stable and reliable. So we're starting to look at some of these things, beta amyloid, tau, and tau levels in the cerebrospinal fluid. We're also using PET scans. We talked about PET scans, actually looking at the areas of the brain that are utilizing the most glucose. And an Alzheimer's disease is often associated with reduced use of glucose in the brain areas, particularly those areas of the brain that are important in memory, learning, and problem solving. In 2012, the FDA approved the first molecular imaging tracer for use in patients being evaluated for possible Alzheimer's disease. And this tracer is a molecule that binds to beta amyloid in the brain and can be visualized during a PET scan. So that's pretty interesting. And that can reveal the presence of amyloid plaques within the brain of living patients. So this enhances our diagnosis. Amyloid plaques cannot be used to diagnose Alzheimer's disease alone, however, because many people have amyloid plaques but don't necessarily have the symptoms of Alzheimer's disease or cognitive decline. And we're not using this as a routine imaging for patients suspected of having Alzheimer's disease just yet. It's not quite yet refined enough. And we don't know if patients who have those plaques but have not yet developed symptoms are at a greater risk for developing symptoms down the road. That's something else that we're looking at. CSF proteins. Research suggests that Alzheimer's disease in early stages might cause some changes in the CSF levels, again, of the tau and beta amyloid. So, we can look at those proteins within the cerebrospinal fluid. These proteins that form in a brain are strongly linked to Alzheimer's disease. And then we talked about genetics a little bit. Genetic testing for the APOE4 is the strongest risk factor gene. Some clinical trials are identifying participants at high risk for the disease, but it's not a currently recommended test outside of research settings because there really are no treatments yet available that can change the course of a patient who has this genetic anomaly. So we see here a couple of PET scans on the left. The PET scan can detect the decline in glucose metabolism associated with decreased cognitive decline, particularly in the temporal and parietal lobes, which are located on the sides and the back of the brain. These regions are associated with memory formation and language. UC Berkeley researchers are finding that brain imaging shows promise as a method of detecting early signs of Alzheimer's disease. We also have a PET scan here showing normal, on the left, is the PET scan showing normal levels of glucose metabolism indicated in yellow and red. The levels of glucose metabolism in the brain are decreased in patients with mild cognitive impairment, which is in the middle there. And then on the far right, you see even further decrease in the patient with the Alzheimer's disease. On the right set of pictures is a PET scan that's looking at amyloid plaques. And the amyloid plaques appear as warm colors like red and orange. The middle scan is a scan from a person with no symptoms of cognitive problems, but has a lot of amyloid in the brain. And again, the FDA has approved this tracer, but we're not using it routinely to diagnose Alzheimer's disease. So this is a patient with Alzheimer's disease. You can see the amyloid deposits in the red and orange. This is a normal patient, no clinical symptoms, but still amyloid plaque deposits. And then this is an amyloid negative brain. So we're just not sure what to do with these patients who have normal cognitive function, but still have this amyloid plaque. And so it's still a sticky area in terms of utilizing for diagnosis. So how do we treat this wonderful disease? The mainstay of therapy is going to be the use of centrally acting cholinesterase inhibitors, and we're trying to decrease the depletion of ACH in the cerebral cortex and hippocampus. Because the clinical manifestations of Alzheimer's are partly due to loss of cholinergic innervation to the cerebral cortex, these compounds interfere with the degradation of ACH by the ACHE. So we'll start treatment with cholinesterase inhibitors, and we'll start this for patients with mild to moderate dementia. We can define that as an MMSE score of between 10 and 26. Choice between these medications really depends upon cost, individual patient tolerance, physician experience or PA experience with the drug, and because the efficacy appears to be similar in all these medications. Technically, in patients with technically we wait until a patient has moderate disease before starting an adjunctive medication. So patients with moderate to advanced dementia, an MMSE score of less than 17, recommendation had been waiting to add the memantidine or the Namenda to these patients. But we're finding a lot of neurologists and a lot in practice that neurologists are starting this medication as soon as the patient has adjusted to the ACH inhibitor because of its potential neuroprotective properties. So Namenda is very well tolerated, generally speaking, has few drug interactions, and so the real question in considering the addition of this drug is, can the patient afford it? So once we've gotten a patient stabilized on an ACH inhibitor and we know which one works and which one the patient can tolerate, we go ahead and start adding that Namenda now. In patients with mild to moderate Alzheimer's disease who are interested in taking therapy with vitamins or are unable or unwilling to take Namenda for some reason, we do recommend vitamin E. The benefits are likely to be modest. It's not recommended for other forms of dementia or for prevention of Alzheimer's dementia. So we don't tell patients to take it just to reduce their risk of getting Alzheimer's dementia. It doesn't work that way. Antidepressants are an important thing to keep in mind because about 30% of patients with Alzheimer's disease will develop depression. It frequently begins before the Alzheimer's disease is clinically diagnosed, and it's really important to palliate this frequent comorbid condition because that can considerably improve cognition and non-cognitive performance. Moving on to vascular dementias. These are going to be the second most common cause of dementia. Results from brain injury caused by stroke and cerebral ischemia. And you can see on these pictures that we have vascular changes on this side. All these areas of white are areas of decreased cerebral perfusion or cerebral ischemia, and we have no vascular changes in this brain. Diagnosis of vascular dementia requires impairment in memory and two other cognitive domains, so things like orientation, language, praxis, executive function, visuospatial skills. These should be serious enough to affect the activities of daily living and be consistently present in order to distinguish dementia from just episodic impairments of consciousness, such as delirium. The other main criteria are going to be vascular risk factors, so things like hypertension, coronary disease, diabetes, also specific evidence of cerebrovascular disease, clinical or radiologic evidence of TIA or stroke. The cerebrovascular insult should precede or coincide with the onset or worsening of cognitive abnormalities. And we really, to call a true vascular dementia, we don't want that insult to be older than 3 months. So within the last 3 months, the patient has some kind of event, that a TIA or stroke that leads to cerebral ischemia, and then develops some cognitive abnormalities. Focal deficits are common, which makes sense when you think about the mechanism behind the disease. If there is ischemia in one area of the brain that's responsible, let's say, for fine motor skills, then that patient will have, in addition to dementia, will have affected fine motor skills. Treatment is going to be symptomatic, including treatment of risk factors for vascular disease, and that's pretty much all we can do here. Lewy body dementia. We talked briefly about the fact that Lewy bodies are a pathologic hallmark of Parkinson's disease. In Parkinson's disease, however, the Lewy bodies are going to be restricted to the brainstem. So that's the only place that you'll find them. In Lewy body dementia, the Lewy bodies are going to be present in a pattern more widespread than we observe in Parkinson's disease. What a Lewy body is, essentially, is an abnormal aggregate of protein, and it develops inside a nerve cell. So we have this large pink circle here that's a Lewy body within a brain cell. The brown section here is going to be normal brain pigmentation, and this here at C is the cell nucleus. So what we're looking at is this right here, and again, just an abnormal aggregate of protein inside the nerve cell. The central feature of Lewy body dementia is going to be a progressive cognitive decline combined with 3 additional defining features. So these patients will have pronounced fluctuation in alertness and attention, like frequent drowsiness, lethargy, long periods of time spent staring into space, maybe just some disorganized speech. Patients will also have recurrent visual hallucinations, and then finally Parkinsonian motor symptoms. So these patients may have some rigidity and loss of spontaneous movement. Again, makes sense because the pathophysiology or the pathology in these disorders is similar. Lewy body patients will also have some decline in executive function and visuospatial impairment that's more prominent than patients with Alzheimer's disease. So the memory deficit pattern in Lewy body's disease is going to be different from that of Alzheimer's disease. Alzheimer's patients virtually always have anterograde memory loss as a prominent symptom early in the course of the disease, and anterograde memory loss is going to be less prominent in the Lewy body dementia. So remember that anterograde memory loss is loss of memory of what happened after the insult, and retrograde memory loss is loss of memory for events prior to the insult. So very crudely, you can remember that Alzheimer's patients have more difficulty with recent event memory, while Lewy body patients have more difficulty with long-term memory. Frontotemporal dementia. This is a group of disorders that result from loss of volume in the frontal and temporal lobes. Patients may present differently based on which structures are atrophied. There is a relative sparing of memory, though, in frontotemporal dementia. The most common early presentation is a patient with gradual character change and disordered social conduct. So a previously demure person may suddenly become very inappropriately disinhibited and start shoplifting, for example, just doing something very out of character for them. The mean age of onset in this type of dementia is earlier than your average Alzheimer's patient. Pick's disease is a particular variant of frontotemporal dementia, and I believe we have this on the next slide. Yep. Pick's disease is linked to chromosome 17. These patients become very aggressive and socially inappropriate. They also exhibit what we call, and I cannot speak German, usually I ask a student in the room to pronounce this for me, so I'm not going to try to say this word, but it is inappropriate jocularity. So they're laughing at silly jokes, just very heartily. You'll also see some echolalia and echopraxia with these patients. So these patients may repeat the examiner's words or may imitate the examiner's gestures as well. Moving forward to normal pressure hydrocephalus, this is a classic triad of dementia. Gait apraxia, which is a wide-based magnetic gait, and urinary incontinence. If anything's going to be missing from the clinical picture, most often it's going to be the urinary incontinence. The dementia in NPH is characterized by memory problems, poor attention, and slow information processing. And again, when we talk about this gait, typically it is magnetic and wide gait. It's called a gait apraxia because the patient's lost his ability to produce purposeful, skilled movements. Interestingly, lower extremity strength in NPH is preserved. So let's take a look at the gait of an NPH patient.
Try to take some steps.
See, he's very wide-based. Okay. His feet are almost stuck to the ground.
Now, see if you can keep going without pulling him.
The examiner was helping him along.
Try to take some steps.
And has stopped now. So he's magnetic. He's stuck to the ground. Okay. Good. The primary mechanism behind the formation of NPH is going to be the impairment of reabsorption of the CSF. And what's responsible for CSF reabsorption are the arachnoid granulations. 50% of these cases are going to be idiopathic. The remaining cases are caused by subarachnoid hemorrhage, head trauma, infection, and elevated CSF protein levels. Brain imaging here will show ventricular enlargement, and the diagnostic test of choice here is going to be a therapeutic LP. So what we'll do is we'll draw off 20 to 50 cc's of CSF and then retest gait and cognition. So the patients who transiently improve are most likely to benefit from the placement of a VP shunt. So what happens with the VP shunt, that you can see right here, is the excess CSF is diverted from the brain into the abdominal cavity. When we place these, we'll cut a flap in the scalp. A small hole will be drilled into the skull, and a little catheter is put into the ventricle of the brain, and then we tunnel that catheter under the skin behind the ear, down the neck and chest, and into the peritoneal cavity. Parkinson's dementia. About 50% of Parkinson's patients will become demented by the time they reach 85 years old. Parkinson's dementia affects executive functioning more than it affects language and visuospatial processing. And remember, executive functioning is that high-order thinking. We test it by asking patients to explain proverbs, things like don't cry over spilt milk. A patient who has lost his ability, his executive functioning abilities, might explain that very literally. So rather than saying, when you make a mistake, don't dwell on it and get up and move on, which is really what the proverb is telling us, the patient who's lost executive functioning might literally tell you that you should not shed tears if you knock over your milk at breakfast. And that's how he will explain that proverb. So again, these Parkinson's dementia patients have more effect on executive functioning than they do on language and visuospatial processing. Patients with early Parkinson's or early onset Parkinson's disease are going to be less likely to develop dementia, which is good news for Michael J. Fox, as he developed his Parkinson's disease very, very early. And there's no specific therapy for treatment of Parkinson's dementia, but it's important to aggressively treat concurrent mood disorders and any psychosis that might be present. The last form of dementia we're going to talk about is Creutzfeldt-Jakob Disease, or CJD. It is a group of prion diseases, and prion diseases are transmissible, subacute, spongiform encephalopathies. Do not memorize that. The transmittable agent is going to be an isoform of the prion protein. What you need to remember is that it is transmittable and that it is caused by a prion protein. It can be, CJD can be sporadic, inherited, or it can be acquired. So there are lots of different ways that the disease can be transmitted. The intracerebral route is the most efficient for the disease. And we have seen transmission occur as a result of improperly sterilized intracerebral electrodes and cornea transplants. This is the disease also that is associated with mad cow disease. So there's evidence that ingesting contaminated beef or products can lead to CJD. Certainly the ingestion of an infected brain can lead to the infection. And that's no joke, because there's actually, there was a group of folks who contracted the disease in 1997 from eating squirrel brains. And this happened in Kentucky, I believe, which is sad and terrible because I have family from Kentucky. But hopefully they were in the hills, in the sticks, and eating squirrel brain. And my apologies to any of you who enjoy that particular delicacy. The disease typically affects patients between the age of 50 and 70, and 5 to 10% of cases are going to be are familial and are going to be autosomal dominant inheritance. So what we see in Creutzfeldt-Jakob disease is a subacute course with a clinical triad of dementia, myoclonus, and then there are some characteristic EEG findings. What we see on EEG is going to be diffuse slowing of the background activity, so the EEG just looks very slow, and then periodic spikes in the EEG. Patients usually decline virtually on a weekly basis, quickly becoming mute, bedridden, and have very little movement except for that myoclonus. And CJD is uniformly fatal. Death usually occurs within 6 to 12 months of disease onset from respiratory complications, and survival is very rarely prolonged over a year. And diagnosis here is going to be very, very important. We're going to do an MRI, and the MRI is going to show increased signal intensity in the caudate and the putamen, and you can see that on the next slide. And then the thing that you really need to hone in on here is going to be the CSF 14-3-3 protein test. So that's going to be positive in 88% of sporadic CJD patients. So 14-3-3 prion protein test. Here's the MRI of a brain affected by Creutzfeldt-Jakob disease, and you can see here that we have some increased signal intensity in the caudate, which is the white arrows, and the lentiform nucleus, which is going to be the black arrows here. So that is our discussion of dementia and memory loss. If you have any questions, please don't hesitate to contact me. This is sort of my first go this morning at recording this, so please forgive any of my hesitations or bumps in the road. And I will see you next Monday.